For my leadership project, I chose to make an acuity scale for our telemetry unit. The title of my project is Development of an Acuity Scale for a Telemetry Unit. First I want to tell a little bit about why I chose to make an acuity scale. So I started working last July, and I noticed that we just break up the patients' rooms 501 to 506. It doesn't matter what they have. I could have 3 peg tubes and 5 dressing changes, and then the next nurse in 507 to 512 might just have alert and oriented patients independent, and then she's sitting down all day, just documenting, having time, and then I'm just struggling. So I asked somebody, I was like, why don't we have an acuity scale? Why don't we break our patients up based off of a different, sort of like a level system, like what they have? And so I asked my boss, and she said that they had tried some in the past, like they tried 2 or 3 and they failed. And I was trying to figure out why they failed, and I just think it's because we didn't have the time to put into it to actually assign patients the way they should be assigned. So that's where this came from. For the problem with the thing is it's not safe for patients to have a nurse who has to give all her time to all 6 of them. Like, a nurse needs to be able to do extra things for her patients, like educate, teach about new medications. I barely have time to do that with the scale we have now. Well, the lack of the scale. So the purpose of my project is to increase patient safety and evenly distribute nurse workload. I really think that that'll make nurses, they won't feel as burnt out during the day. Like, they'll have maybe 3 alert and oriented patients, and then they can give their more time to the really needy patients that have a lot of stuff going on, a lot of IV antibiotics, dressing changes, dialysis patients that just had a heart catheterization, they're coming back to the unit, you got to do checks every 15 minutes. Like, all those things add up. So I think having this acuity scale is really going to help our floor. Let's see. First, like how I got started, I just started researching acuity scales. Like, I used Google, I used, our research tools, and I found that other people have been trying to do this same thing. And I found one source that was saying the acuity scale, they had like 19 different things broken up, but that's going to take a long time, to make. So I tried to make one that was fairly simple. But first I surveyed all the coworkers. I asked them, I was like, what can we do, to alleviate some stress for your job and just break everything up evenly? Like, what kind of things do we need to consider a level 1, a level 2, a level 3, or a level 4? Like, what things make these patients more complicated? And I also asked the nurses, like, do you feel burnt out working the way you work now? Like, is there anything else we can do to help alleviate the problem? And I got some really good feedback on that, and I used their advice, and I just tried to, like, make something concise, something easy, that they don't have to jot down a lot of notes, but all they have to do is just assign a number to their patient. So here's my sample. This isn't the final one because I've got it printed at work, but this is what it looks like. You've got your date and your shift. It's a shift report. So each nurse would have their own piece of paper, and it changes shift. They would go through and assign their own patient what they thought the level of the acuity should be, so that the charge nurse can then break it up and give somebody a few level 1s plus a level 3 and a level 4 and another level 3 or something. But the problem is most of the patients on our floor pretty much qualify level 3 or level 4. But you do have the 1s and 2s that are in there, and that makes your day a lot better. So, like, our floor is 501 to 535. Those are the rooms we use. So I've got 501, 502. You've got some big boxes right here and some small boxes. The small boxes are dedicated for a number 1, 2, 3, or 4. The big box, I wrote on here, please rate your patients based on their activity listed below. Feel free to make notes within the larger box. So you would just be like, this person has a peg tube, but you could say they only get meds. There's 1 med pass. That's it, just 1 med pass. And so that changes things. That doesn't take too long. You've still got to do your Q4 flushes or whatever the doctor ordered. but it still makes life easier. So I've got my level 1, level 2, level 3, and level 4. Level 1 would be the patient up ad lib without assistance. They can just get up, they're walkie-talkie, they're safe to be up, they're alert and oriented, they have a Foley. With a Foley, that's not going to take up much time. I mean, yeah, you have to do your daily Foley care and assess if they still need it, but that's not going to change too much. Finger sticks, at our hospital, our aides do our finger sticks for us. I don't know how it is everywhere else, but that helps. An NG tube, but no suction, so you don't have to just change the container, empty it, measure it, document all that. They just have an NG tube because they're NPO, and that's how you give them their meds or their anything like that. And then if they have a 1-to-1 sitter, like they might be a level 4, like they might be confused, but if they have a sitter, that takes so much weight off the nurse. So I would consider that a level 1 because they have somebody watching them at all times, and I don't have to keep running to the room to make sure they're in the bed and not in the floor. Level 2, it's an isolation patient with simple dressing changes. You know, just Atomepilex, nothing complex. Up with assistance, probably 1 assist, something we could do on our own. Pain meds Q4, PCA pump, IV antibiotics, blood transfusions, NG to suction, bed alarm. That'd be a level 2. Those things take a little more time because you know with a blood transfusion, we can't leave the room for 15 minutes. A level 3 would be tube feedings, neuro checks every 2 hours, frequent pain meds like your Dilaudid, which is like every 2, finger sticks every 2 hours, heparin drip, insulin drip. As on our floor, we might have a Cardizem drip. And then level 4 would be complex or multiple dressing changes. That'd be somebody that came in with many pressure sores, which we have a lot of nursing home patients, so sadly we see that often. Chest tubes, trach care, restraints, a wound vac, extreme personal family dynamics, somebody where the family just, you know how they can wear you out. Extreme fall risk, and getting up frequently. So the thing with our floor too is I feel like a lot of people are high fall risk because we're always given antihypertensives or Ativan, something to help relax them, calm them down, because we have a lot of older people who are very confused when they get to the floor, as in most places. So, but I think breaking this up is going to help. We've only been using it about a week, so, you know, once I got it all done, I still need to keep assessing it after this project is over, and I'm sure there'll be things I'm tweaking, you know, to make it even better. But it's been an improvement. There were some limitations to the project. Like I would go to work and I'm trying to teach the charge nurse about the new scale, but she doesn't have much time to listen because she has 6 patients she cares for. So I think one thing our floor really needs is a charge nurse with no patients, because then you have that time to actually make patient assignments, make safe bed assignments. Now we'll be putting patients that are confused, they'll stick them at the end of the hallway, not near the nurse's station, because we simply don't have a bed available. Like we need somebody to be the middleman and say, hey, this is not safe, this is not best for the patient. Let's see if we can move somebody who's more stable, you know, to a room further away, and let's just see how we can rework the floor. So I think once we get that situated, we'll have a lot more time to work on the acuity scale and make it better assignments. And I think that'll give the nurses more time. I mean, they'll have time to chart. You know, sometimes our patient notes are slacking. They'll have time to, you know, do education. Like a lot of times we don't have time to educate until discharge, which I know you can work it in with your med pass, and you can work it in while you're assessing, you know, while you're assessing their breathing. Just teach them, hey, it's good to turn, cough, and deep breathe while you're in the bed to prevent pneumonia. Like there's little things you can work in there, but it would also be better if we had a lot more time. We could use teach back methods. We could assess them many times during the day to see if the teaching needs to be reinforced, if they're retaining the information. So I feel like we have a long way to go, but I think it's awesome that we have a starting point. And that's about it. I mean, overall, I really enjoyed this project. It was great. Got me closer to my director, and just the support she had, I just hope I can give that back to somebody someday. So if y'all have any comments or anything, please let me know. Anything y'all think I can do to make it even better, because I'm sure y'all probably have some good acuity scales. You know, everybody being from various hospitals. But thank you.